So good afternoon, good evening, everyone. My name is Kyle Nuland. I am one of the joint replacement orthopedic surgeons at University Orthopedics. And we had prepared for you a lecture today on partial knee replacement. Normally I see patients with hip and knee arthritis and symptoms of pain in their hips and knees. And so I like to often have a discussion with them about what solutions we could have. And oftentimes with the knee patients in particular, this boils down into selecting eventually if they're still having pain after conservative management, what kind of knee replacement would be best for them. And so this idea of partial knee replacement has really made its way into our practices and into the literature. And I think oftentimes patients come in now kind of being told, oh, maybe you'd be a candidate for a partial knee. And so a lot of our discussions revolve around what the best decision would be for that patient. So on a side note, I primarily see patients in Mansfield and Raynham, and I operate at several different hospitals, including Morton Hospital, Good Samaritan, and at the East Bay Surgery Center in East Providence. So again, today we're going to talk about total knee replacement. I'm Kyle Nuland. I'm a clinical assistant professor at Brown University and practice with University Orthopedics. I specialize in joint replacement. And again, we're going to discuss the ins and outs of knee replacement today, in particular, what a partial knee is and who may be a good candidate for a partial knee replacement. Just quickly for disclosures, for full transparency, I don't receive any payments or any royalties from any of the orthopedic devices that we're going to talk about in this talk today. So what's the agenda? We're going to talk about just generally basic level, what is arthritis? We all hear about, hey, my sister or my dad had arthritis. Well, what exactly is arthritis and how does that impact us? We're going to talk about the anatomy of the knee and how this factors into our surgical decisions and how we end up doing surgery on the knee. And then we're going to go and talk about partial versus total knee replacement. What are the differences? Why would you do one over the other? And how could you, as a patient, think about these two procedures and which you would prefer if you were a candidate? And finally, we'll end with just talking about some of our big studies in orthopedics. What do these say about partial knee replacements versus total knee replacements? And how do these implants hold up over long periods of time? So what is arthritis? Arthritis demographically is a really big problem, and it impacts millions and millions of people around the world. In 2020, about 60 million Americans were diagnosed with arthritis. So those are people that actually went to their physician, got x-rays, and actually have a formal diagnosis of arthritis, whereas there's probably millions and millions of people out there as well who haven't gotten a formal diagnosis. So this impacts about probably 1 out of every 4 or 1 out of every 5 Americans. So this is a really, really big problem in healthcare. And you can see on this graph as time goes on, as this baby boomer generation ages demographically, the amount of people with arthritis in the United States is only going to increase. Economically, this also represents a pretty large burden for our society. So in 2013, which is kind of some of the latest data we have on this, the national costs of just arthritis were over $300 billion, which is a massive number. And about half of that were from formal medical costs, seeing doctors, getting treatments, having surgery. And the other half were from lost wages, so time out of work, because people, their knees hurt or their hips hurt and they can't do their normal jobs because of arthritis. So both societally, health-wise, and economically, arthritis is just a very big problem. And I'm quite interested in my practice in how to help people deal with arthritis. So let's get into the nitty-gritty a little bit. What actually is arthritis? We throw this term around all the time, but what actually is going on inside of our bodies that cause arthritis? So on the left here, you're seeing a normal knee. You're looking straight on at someone, and the knee is basically a hinge joint. The knee is where the femur, the thigh bone, and the tibia, the shin bone, come together and create a joint. So it's just like a hinge on your door, or any other hinge you see. The ends of those bones, though, the femur bone and the tibia bone, have to be lined with this cartilage. That's how your body keeps your joints lubricated, is it lines the ends of your bones with this nice white frictionless surface, so that when the two bones move with respect to each other, there's no grinding. There's no bone that's rubbing on bone. And if you imagine a real hinge in a door, if that hinge gets rusty, the confluence of motion is restricted. You don't get this smooth, symmetric motion. You get this rubbing. And that's exactly what happens in our joints. As that cartilage wears down, as you can see on this right picture, as that cartilage wears down and gets thinner, you no longer have this nice bearing surface for the knee to move around. So when the joint starts to sense that, it actually starts to build up this extra bone. You see this extra bone on the inside of the knee. These are called osteophytes. That's a hallmark sign of arthritis. And what your body is actually trying to do is it's trying to stabilize that joint by building extra bone. So the loss of cartilage is kind of creating this instability within the knee. And often patients will come in and talk about, well, I just can't trust my knee anymore. It gives out on me. It doesn't feel as stable raising up from a chair. I don't feel like I have my full weight under me. And this is why that happens. You no longer have that nice frictionless symmetric surface. And instead your bearing surface has become basically bone on bone. And you can imagine bone rubbing on bone is extremely painful. And that's a lot of times why patients have all these symptoms with arthritis, is when they're walking, the bone is rubbing on another bone. Our cartilage naturally doesn't have any nerve endings in it. So every time you walk with good cartilage, you don't feel any pain. And that's kind of the body's natural design to allow you to go about your daily life without having pain in your joints. You don't want the cartilage to have pain fibers and nerves in it, because every time you'd walk, you'd have pain. The bone is a completely different story. The bone actually has rather significant nerve endings in it. So once you get to the stage of bone on bone, each time you're walking on that, the nerves are firing and telling your body that you have pain. And so that's why people experience this. And one of the reasons why people experience this pain in arthritis. So when patients come into the office, this is actually what we're looking at. We're getting x-rays of your knees or your hips or whatever joint we're talking about, to look at the space that your joint still has. So this is a kind of a nice synopsis from left to right of what arthritis looks like on an x-ray. So on the leftmost picture here, this is looking straight at someone's knee. So you see the femur, this is the thigh bone coming down, and this is the tibia, the shin bone coming up. And where they meet, you see this empty space, right? That's actually where the joint is. That's where the hinge is. And the reason there's empty space there is, like the previous slide, if we went in and looked at your knee, the inside of these bones would be covered in cartilage here. The cartilage is soft and it's full of water, actually. So the x-ray doesn't show it to us. An MRI or other imaging may show it to us, but the x-ray doesn't show anything there. It just shows this empty space. But because we know the cartilage is supposed to line the bones there, we know that that space reflects how much cartilage is left. And so if we know that arthritis is just the wearing down of that cartilage, the thinning of that cartilage, we know that as those spaces get smaller and shrink, that's basically representative of someone developing arthritis. So if you move from this left picture to the middle picture, you'll see a few things. And this is kind of a mid-stage arthritis. This is an end stage, but this is someone who comes in who has, kind of a medium amount of arthritis. The first thing you'll notice is these spaces are just slightly narrower, and that cartilage has been thinned just a little bit. The other thing you'll notice is the ends of the bones are no longer as smooth. So if you compare it to this left picture, the ends of the bones are quite smooth. You don't see any additional bone here. There's none of those osteophytes. When you start to look at this middle picture, you see these little rims of bone that have kind of spun off of the actual joint surface. Here's one on the femur. Again, here's one on the tibia. You see on the lateral or outer aspect of the knee, this little osteophyte as well. And like we talked about, that's because the knee is starting to experience a little bit of instability. It's losing cartilage, and the body is naturally producing more bone to try and restrict the motion and rebalance the knee. And so if you go all the way to the right picture here, this is a good picture of advanced arthritis. So you'll see we can no longer see any joint space. We can't see any space on the inside of the knee. This person is completely bone on bone. You see these large osteophytes of extra bone that have been built up. And then as well on the lateral side, we have a little bit of space left, but there's again these large osteophytes spanning off of the bone. So if you compare someone on the left side who's walking around, they have this nice fluid motion. They don't have any pain because their cartilage is intact there. Whereas on the right side, this person's bearing surface is now completely rusty. And every time they walk, their bone is rubbing on their bone, which causes really severe pain and difficulty doing their everyday activities. I want to point out that arthritis is really a quite multifactorial process. So patients often come in and say, is it my age? Have I put in too many miles on my knee? There's plenty of people who are marathon runners or have, put millions of miles on their knees and don't develop arthritis. And the reason is this is multifactorial. This is really the development of arthritis, and the thinning is a combination of your genetics, what sorts of proteins and cartilage you make. So you can thank, your parents for any arthritis that you have. And I usually ask patients, do your mom or dad have any problems with their knees or hips? So it's a combination of your genetics and your lifestyle. What other medical problems do you have? Do you have inflammatory disorders of your joints, like rheumatoid or psoriatic arthritis? Do you have diabetes where your sugars are high? That can impact the survival of your cartilage cells and how thick your cartilage is. And then obviously, if you've had trauma previously in your life, if you had a fracture or something in one of your joints, that can create kind of an asymmetric surface, which then can lead to more rapid progression of arthritis. So this really is a multifactorial process that takes kind of your genetics and your lifestyle into play, and that can determine how quickly or if you even develop arthritis at all. So let's transition a little into knee anatomy. So anatomy of the knee is really how we understand the knee, and how we ultimately end up learning how to operate on the knee is learning all these structures and what they end up doing for the knee and how they keep you feeling good. So these are two versions of the knee. On the left side here, we have a knee that's straight, so fully extended, right? And on the right side here, we have a knee that is flexed. So imagine sitting in a chair and bent. And there's lots of arrows here, so it can become a little bit overwhelming, but the main structures you really want to understand in the knee are the condyles. So these are called your condyles of your femur, these little outposts. These are kind of the bearing surfaces of the knee, and you see that these are lined with cartilage, okay? These articulate with the tibia and what's called the tibial plateau. So again, you have a little segment of your tibia right here on the inside, and one on your outside where these condyles of the femur kind of roll forward and back on. Between those two structures, the femur and the tibia, not only do we have the cartilage, but we have the menisci. You have one on the inside called your medial meniscus, and one on the outside called your lateral meniscus. And these, almost you can think of them like saddles for the condyles. They help protect the weight-bearing surface, and they help disperse the force of you walking around, so that not all the force goes through the cartilage. It actually disperses through these fibrous bands called the menisci. On a quick note, when people come into me and they have advanced arthritis of their knee, when all this cartilage is worn down, and they no longer have any space between the two bones on the x-ray, realize that the meniscus is inside, it's between those two bones. So if that space shrinks to nothing, by definition, this meniscus is also significantly damaged. So when people come in and they say, I have a meniscal tear in the setting of really advanced arthritis, the meniscal tear is really a secondary process because of the arthritis. And so fixing that meniscal tear doesn't often lead to a lot of relief because you're not getting to the main problem. To just quickly round out the other structures that were that are quite important. Everyone's heard of kind of your cruciate ligaments. The most famous is your ACL. You hear your NFL players all the time, you know, ACL rupture, out for the season. This is called your ACL, or your anterior cruciate ligament. And this other fibrous band here that kind of crosses behind is called your PCL, or your posterior cruciate ligament. These are obviously called the cruciates because they form a cross in the middle of the knee. Okay, and these are quite important for your natural knee's biomechanics. And when you're doing twisting motions or walking around, these help keep your femur and your tibia stable, both rotationally and kind of what we call in a varus valgus moment, how much the tibia kind of goes off to one side or the other. And to round it out, we have your collateral ligaments, which are quite important. You see this thick band here on the inside. That's called your MCL, or your medial collateral ligament. And that really prevents the tibia from going towards the outside. Again, you'll see these slow motion replays in football games where someone gets tackled and the tibia kind of goes off to the side. You can imagine that stretches the MCL. So the MCL is quite important in resisting the tibia from going off to the side. And so just like you have a medial collateral ligament, you have a lateral collateral ligament, and that goes on the outside of the knee and basically does the opposite of the medial collateral ligament. So lastly, when we look at the knee flex here on the right side, we're getting a straight-on shot of all this cartilage that lines the femur. So you see all this cartilage that lines the femur, and it gives you a better idea of what we refer to as the different compartments of the knee. So every time you walk around, the weight bearing of your knee is going through a few different places. It's going through the inside here, where this femoral condyle contacts the tibia. It's going through the outside here, where this lateral condyle impacts the lateral part of the tibia. And then you'll notice when the knee is bent, you also have this really important articulation of your patella. So your patella, your kneecap, sits in this special groove on the femur. And as you bend and straighten your knee, that kneecap actually goes up and down and up and down. So the crucial part about this is you can imagine you could develop arthritis. Your cartilage could wear down on any one of these compartments. So you could have isolated wear of the medial or inside compartment, isolated wear of the outside, or even isolated wear of the patellofemoral compartment right here. I like to kind of re-emphasize this by thinking about a rocking chair. So when you rock back and forth on a rocking chair, you kind of have two main weight-bearing surfaces here that go back and forth. If one of these pieces of wood were injured or broken, you wouldn't fix both of them. You would just fix one of them, whichever one is broken, assuming the other one was still working. And that's kind of how we can think about knee replacement. If we just have one of those compartments that's kind of broken and arthritic, you know, we should just replace that one that's injured to preserve the rest of the knee as much as possible. So this kind of transitions into our talk specifically on partial knee replacement. So again, when we talk about a partial knee here on this side, this is called a medial partial knee replacement, or an inside partial knee replacement. So what we've done is we've taken off a little bit of bone and replaced it with a new bearing surface, just on the inside of the bone. But what's that allowed us to do is keep all of these other structures. If you remember back to your anatomy, the collateral ligaments and the cruciate ligaments and the lateral compartment, we've kept all of that in place. And so that's kind of led to a knee that's more biomechanically related to your normal knee instead of kind of a completely reconstructed knee. And you can apply that principle to other compartments in the knee where, again, we could just do an inside partial knee, we could just do an outside partial knee, or we could just replace that articulation that we talked about between the patella and the femur. And so all of these different procedures are really known as partial knee replacement. And then we kind of become more specific when we talk about what exact compartment are we replacing. So this is an example of a patient that came in to see me. And they'd been having this inside knee pain for around a year, and this was starting to prevent the patient from going to work and doing their daily activities and working around the house. And when they came in, they basically just pointed to the inside of their knee. So I like to, have patients show me, where exactly do you hurt? And when that hurt corresponds to exactly where their arthritis is on the x-ray, that's starting to tip me off that this could be a patient that would be a great candidate for a partial knee. So you'll see here, again, when we look at the spaces between the two bones, the inside here of the knee is completely bone on bone. There's no space there. You see this little osteophyte formation. And you compare that to the outside of the knee where we still have this nice space there. So if this person basically has isolated arthritis just on the inside of the knee, and so if all the rest of their knee was intact and healthy, to replace that whole surface with a total knee replacement, I think would be a little bit overkill. And so what we did is a partial knee replacement. We just replaced this inside of the knee with some metal and plastic. We built them a new bearing surface so that the only thing we had to replace with this small amount of medial bone. And we left the rest of their knee intact so that when they walk around, they still have that feeling of stability like a normal knee, because their cruciates are still intact, their lateral compartment is still intact, and their patella is still intact. This is what the components actually look like in a total knee. So you always are really putting in 3 new components when we do a partial knee. You have this femur component. This lies on the femur, okay? That's the femoral component. That's usually made out of kind of a stainless steel or a ceramic special composite. And then on the tibia side, you usually have this either titanium component that sits on the tibia. And in between the actual bearing surface is this special plastic called polyethylene. And this is kind of this engineered plastic that we use a lot in orthopedics that has very good wear properties. So after millions and millions of cycles, this polyethylene has almost no wear, which allows it to be a very good bearing surface in any replacement that we do. So historically, after this part of the talk, you're wondering, well, why would we ever not do a partial knee? And so we kind of have to go back in history a little bit to look at when the first partial knees were done, why did they fail? And so this is called the Cozen and Scott criteria. This came from a published paper back at the end of the 1980s about these 2 surgeons, Cozen and Scott's experience doing partial knees. And so on the left side, you see these are what are called contraindications or indications. What patient specific criteria has to be present for us to do a partial knee replacement versus a total knee. And so initially they thought that the arthritis can only be isolated to the inside compartment of the knee, like we talked about. And after some more recent studies, we figured out, well, the patella probably can have a little bit of arthritis in it, and we can still do a partial knee, and people do very, very well. Okay. What this says, though, is people cannot have arthritis on both the inside and the outside, the medial and lateral compartments, because obviously replacing just one of those is not going to fix the problem if both sides are arthritic. The way I usually like to tease this out in the office is the x-ray, like we talked about, it can't have any arthritis on the lateral side, but also I like to press on people's lateral joint line and see if they hurt there. And if a person has pain there, then a partial knee probably is not the best procedure, because they're showing symptoms of having arthritis that's symptomatic in both the inside and outsides of their knee. The next thing that they talked about was the ACL. Could someone have an ACL rupture and still get a partial knee replacement? And they initially thought that that was not a good idea, because that ACL being gone leads to some instability in the knee. And they weren't sure if we did a partial knee replacement would that knee go on to fail in other places because the ACL was not intact? And we've kind of loosened up on that as well recently, where if someone has no ACL, but they have a stable knee, or they have, if their knee feels stable on exam, we still could consider a partial knee in those patients. The next thing they talked about was inflammatory arthropathy, and that's just a fancy word for is the reason you have arthritis secondary to an inflammatory condition. So people with rheumatoid arthritis or psoriatic arthritis, they're thinning their cartilage because their bodies are creating an immune response inside the joint, which is causing the wearing of their cartilage. And so by definition, that is impacting all of the cartilage within someone's knee. So to do a partial knee replacement in someone with rheumatoid arthritis, we tend to not do that even to this day, because we know that process is impacting their entire joint. And the answer for these patients is really a total knee replacement. The other quickly things that they talked about was the weight. They initially thought the weight of patients could not be over 82 kilograms, which is, around 170, 180 pounds. And our more recent studies show that there's no difference in failure rates or revisions in patients with elevated BMI. So that doesn't factor as much into our decision making as much anymore. They initially thought that the alignment of your leg could only be so far off of normal to do a partial knee. And we've kind of, again, expanded those definitions into patients with fairly more deformity. I wanted to just dive a little bit deeper into these. One way we look at deformity in patients is we get what's called a scanogram in the office. So a scanogram is an x-ray of your entire lower extremities. So you'll see someone's pelvis is up here. This is their right hip. This is their left hip. And this x-ray is showing their entirety of their lower extremities. So their femur, their tibia, their fibula, and their ankle joints down here. The nice thing about this is it gives us a sense of someone's alignment. So you could imagine if someone's femur comes down like this, someone who's very knock-kneed, their tibia would go out this way. Or if someone's very bow-legged, their tibia would go in this way. And what this does is it allows us to plan our surgery, and in particular for a partial knee, we don't like to see more than around 10 to 15 degrees of this malalignment. And so a scanogram is one way in the office we could help narrow down if you're a candidate for a total knee replacement, and it would be based on how straight your legs are and where their alignment sits. The other thing I like to do in the office that I think is quite helpful is what's called a stress view. So this is the same patient that we talked about earlier. We see this isolated medial arthritis, this narrowing here. The lateral compartment looks good. And what I do is I get one x-ray with a stress view. So I try and push their tibia out to the outside to see if their alignment corrects. So you can kind of see their alignment here. The tibia sheets inward. When I put this stress on, you see this medial compartment open up and the alignment becomes straighter. So this is a great x-ray for me because I know a partial knee is not going to put too much stress on the rest of the knee because their deformity corrects. And so if this were rigid, if this side of the knee was so tight that on my stress view it did not correct, I don't think a partial knee would be able to make that knee straight again, and we would guide that patient more towards the total. And then lastly, the other study that I think is helpful that we can get is an MRI. So an MRI is kind of a fancy x-ray machine, but it shows us the soft tissues of the knee as well as the bones. So this is the same patient. You're looking at the right knee here, and they have this really terrible pain on the inside of their knee. On the x-ray, they still have some space there. So I'm not thinking about advanced arthritis just based on the x-ray. But if their exam is a little bit concerning to me, and I think maybe they have either a non-displaced fracture or a lot of their cartilage is gone that we're not seeing on the x-ray, we can get an MRI to look a little bit closer into that joint. So this MRI is looking at the exact same view as the x-ray. We're looking straight on at the knee. The bones are dark instead of light on the MRI. And what I'm looking at again is this inside compartment. So here on the X-ray, even though it looks like there's some space there, on the MRI, we see this big white signal. That's what's called edema or swelling in the bone. And underneath that, we should see nice cartilage. And we don't. We see this big defect where there's no more cartilage left. So even though the X-ray is saying, I think we have space here, we get the MRI based on this patient's symptoms, and the patient has this very isolated deficiency of cartilage on the inside compartment of their knee. So this is another great candidate for a partial knee replacement. And we arrived at that through this workup, through getting an MRI. And so lastly, to close out, a picture is kind of worth 1,000 words. So this is side by side a partial knee versus a total knee. So again, the partial knee, in this particular case, the inside partial replacement, left the rest of the knee intact with all those ligaments and soft tissues. Whereas when we do a total knee, we're taking out that whole beginning surface of the tibia as well as the femur, and we're putting in a whole new hinge joint here. So in order to do that, you can imagine we have to usually take out some of those cruciate ligaments, at least the anterior cruciate. And you're left with a new joint surface where people are often very happy with the total knee, but sometimes it doesn't feel quite like the natural knee that you had, when you were 18 and 20. And that's, I think, really in part because we're changing the biomechanics and we're not leaving all those natural structures in your knee when we do a total knee. So again, I like to end on, with all this hype of the partial knee, why would we ever do total knees when we think that partial knees feel more natural and they recover faster, and we get to leave most of your knee intact? Well, this was a study from 2013, and this is called a Kaplan-Meier survival plot. So what this does is it creates two lines here. This blue line is for total knee replacements, and this red line is for partial knee replacements. And what it does is it shows us on the x-axis here how much time we have for follow-up, and on the y-axis what percentage of those knees that were put in are still working well. And so if you see the slope of this red line, it drops farther than the blue line. And what that means is that 8 years out, around 90% of the partial knees were still working well, whereas about 98% of the total knees were still functioning well. And so what that tells us is, over time, we tend to have a slightly higher revision rate with the partial knee compared to the total knee. And so that's one reason why we don't just go and do partial knees in everyone, is we're really trying to select the right patients to get a partial knee, because we know that there is a possibility that that knee fails a little bit faster than a total knee would. And the ways that that partial knee would fail, as you can imagine, we're only replacing part of the knee. So someone could go on to get arthritis in the lateral, the non-replaced part. So that's a reason why we would have to possibly revise a partial knee to a total knee. Or you can just think about the fixation surface, the part where this implant really attaches to your bone is quite a bit smaller than your total knee. So on a total knee, we have this nice big fixation surface, and a partial knee is this little small area. So the way that that binds to the bone is sometimes thought to be not quite as strong as a partial knee. And so we do see occasionally these partial knees fail where this component tends to start dipping down and failing. And so those are the main reasons why in this earlier study in 2013, we found a slightly higher revision rate in partial knees versus total knees. And so that's one reason why we really want to have a big discussion in the office with patients about whether they're suitable for a partial knee and whether we think that their knee would last as long as a total. To round it out, we have some newer studies on this, and this was a recently published study out of the United Kingdom, and this was kind of the largest randomized prospective trial that we have comparing partial knees with total knees. And has a lot of data on it, but I want you to focus on this column is the partial knee, and this is the total knee. And what they're looking at is patient satisfaction with these procedures. So they ask the patients at various time points up to 5 years after the procedure, does your knee feel better than it was before surgery? Would you still have had this operation now after going through the recovery? And how long did you stay in the hospital after this operation? And so these numbers in parentheses are the percentage of patients who said yes. So they felt better compared with before surgery. And if you could just compare the partial numbers with the total numbers, they're consistently a little bit higher, farther out, even up to 5 years, saying that people felt better with the partial knee versus the total knee. And so again, if you ask them, would they still have the same operation? Again, the partial knees were more likely to say they would have the same operation compared to the total knees. And so what we really get from this data is patients tended to have greater satisfaction with the partial knee even up to 5 years, and we only have 5 years of data with this study. They tended to spend less time in the hospital with the partial knee versus the total knee. And they tended to have less medical complications. So that's blood clots, infections, pneumonias, all of that were slightly less with a partial knee. Again, it's a smaller surgery than a total knee. And then to end up, like we talked about before in 2013, we did think that the revision rate was higher with the partial knees. And there's a few reasons for this that we won't get into. But this latest study actually showed the revision percentage between our partial knees and our total knees in this randomized study to be around 4% each. So they were fairly equal. And again, this wasn't hundreds of thousands of patients. It was only about 500 patients. So it wasn't the largest study of all time. But we're starting to get more and more data now where the revision rates of partial knees may be closer than we think to that of totals. And so I think to end on, the partial knee is a fantastic option for patients with this kind of isolated arthritis, pain on one side of the knee. And I think especially patients who are trying to stay very active and retain that more normal feeling knee in comparison with a total knee. And so I think it's great that this awareness is starting to spread. I think this is a fantastic procedure for patients to have access to. And I think surgeons are really, the crux of it is to have this long conversation with patients in the clinic based on their imaging and their symptoms, and to talk to them about whether they would be a candidate for a partial knee. So I think that's basically my synopsis of it. I enjoy these procedures. I think patients do incredibly well, and in my experience do recover faster than a partial knee and get back to their activities faster. And so I think this is a great procedure that we have in our armamentarium for patients that qualify for it based on their symptoms and imaging. So just a few questions came in, which are really excellent questions. The first one was, if you need a revision surgery, does it become a total knee replacement? So if you do a partial knee on someone and that fails for whatever reason, would the next step be a total knee? And probably in 95% of cases, that's right. And we think that that's another potential advantage of partial knee replacements is you can imagine on this picture, if this implant fails, well, what do? We just go in and we replace it with a total knee. And so that is another advantage. We've saved the rest of the knee with this partial knee. And so the next step procedure, and hopefully you never need a next step procedure, but if you ever did, it would be to convert to this total knee rather than having a total knee fail and convert it to a revision. We do have interesting data on this. You would think that a partial knee converted to a total knee would act just like a normal total knee, right? So someone who had a partial knee converted to a total would do the same as someone who just right off the bat had a total knee. And I don't think that's the case with the data. I think these partial knees converted to totals act a little bit more like knee revisions than they do regular primary total knee replacements. The next question is, on average, what is the recovery time to return to full activity from a partial versus a total knee? And I think this is quite patient dependent. We see a lot of different recovery trajectories in patients. But I do like to tell patients for a total knee, you really have to plan out a good at least 8 weeks for your recovery. I told them the first 2 weeks you may not like me very much because you're really dealing with pain and swelling in the knee and working hard with therapy to get your motion back. I think really by 3 months with a total knee, you're probably about 60% recovered, and by 6 months, you're probably about 85 to 90% recovered. But I think a total knee in and out is really at least a 6 month recovery to a year to get back to kind of all of your normal activities. I think the partial knee is probably around half that. So I think a lot of patients at their 2 week appointment with me after a partial knee just generally feel more comfortable. They're getting around with maybe less of a walking aid, using less of a cane or a walker. And they're able to rehab a little bit more effectively, I think, because we haven't done as big of a procedure on their knee. I think by 6 weeks, they're probably about 60% recovered, and by 3 months, they're probably around 75 to 80% recovered. I do also think that patients with the partial knees return to work a little bit faster than the total knees. So where someone may return to work, in the 4 to 6 week realm, really depending on what they do with a partial, I usually tell my totals probably at least 6 to 8 weeks before you're returning to work. So these are great questions. I'm more than happy to discuss these with my patients, and I often do in the office on a daily basis. If you have any other questions, you're more than welcome to reach out to my office. My main number is 781-208-5838. And so I hope everyone is well out there, and hope this was informative and help guide some decisions in the future. Thank you so much.